So, what's the trend? Again, I think especially for distal femur, which is kind of what we're going to be focusing on here tonight, as you kind of look over the past 5 years, this is probably one of the biggest locations that have changed management since I was sort of a resident or a fellow, and how people sort of think about, talk about, and sort of treat the distal femur fracture, whether or not be periprosthetic, native, a lot of dual implants now, plate nail combos, plate combos and things. And so you get a lot of stuff that's sort of looking like this, and technology that is sort of advancing with this kind of complicated fracture pattern and complicated injury. But that's not all sort of the just the basics of it, right? What's the bigger problem? These patients also have end-stage renal disease, osteoporosis with periprosthetic fractures, poor bone quality, not much bone, right? Really low fractures, and we'll kind of talk about that as well. So not only within this kind of complex problem of distal femur, but how do we fix, treat, think about sort of some of these bigger issues and problems in these specific patient populations. And so you start looking at things that look like this, right? And again, this is sort of fun for me, probably fun for Dr. Andring, right? But does pose clinical issues, right? How do you gain fixation? How do you gain stability? How do you gain functionality for these patients in your treatment options? And so again, IlluminOss sort of comes into play with that. And so at our institution, when I sort of have a case now with a distal femur or periprosthetic, the residents think, oh, he's going to do the Illuminati, right? And that's sort of what they've now called this magical little device that's going to come and sort of do magic to the fracture, reduce things, and sort of get things sort of better, improved. And again, we'll kind of talk about that. And I actually think there's probably something to that a little bit in a lot of these patient populations. So just in general, what are my indications? When do I think about this? And Dr. Andring can sort of talk about this too. I consider this for bone augmentation now, really more than anything. So missing bone or sort of bone filler, osteoporotic bone, end-stage renal disease bone. But anytime I'm wanting to increase that bone strength or sort of add to the bone that is there, okay? And certainly kind of early on, it was sort of a dual implant. We'll see some examples with that too. Treating it like a plate nail combo or a plate combo with a plate IlluminOss. And I still do that. But I've sort of evolved a little bit to kind of bone augmentation, missing bone filler, kind of increasing that strength of my construct and sort of pushing the limits then for fixation, because I know I have the IlluminOss there as opposed to just the patient's bone. For me anyway, it's not for that young patient, the open contaminated fracture, or if you have good bone. And then obviously you got to think about, am I going to take it out? I don't know, Dr. Andring, do you have any other kind of indications or especially in the distal femur where you think about this for the patient populations you're treating?
Yeah, I think what always got, I think everyone of us who's put screws in bad bone, you always know of like you drill for a screw that goes into air and then you put a screw in and it feels like you just put a screw in butter. Like those are the people, like short articular blocks that you're really trying to hold on to with fixation that you just know the native host doesn't have the bone to support it. So that's where like the bone augmentation really, I mean, it's palpable when you put it in. Like you feel it, it seems to work. What we'll show our stats, it seems to, clinical outcomes seem to work too. So
And so again, why is it nice for me anyway? Again, you add strength, right? Just like plates, just like screws, just like nails. And you can drill through, right? So you can sort of marry those constructs together. And again, when you start talking about bone augmentation, right, or trying to sort of increase the bony stability, not only is it providing that stability, but you can drill into it, right? You can add to it. And so it sort of becomes that patient's bone, so to speak. And it's really easy insertion with minimal blood loss and quick. I'll let Dr. Andren kind of talk about some of the data that we sort of pulled for our distal femur.
yeah, so this is just a slice of it from kind of when I was exiting residency with Dr. Halvorson. So we have more patients now, but trying to just try to give a flavor of kind of the people we were taking care of and like the some of the results. We got to save some of that for our publication. But here, you can see this is just a 17 patients. You can see they're all your elderly, mostly female patients. Nothing too, they're the typical people you expect to put, these types of implants in. We had over 6 months of follow-up. And you'll see it's kind of odd. You see signed surgical consent. And the other thing I'll add on here later is the ASA. And, our ASA for most of these people was like 3.3. But I will tell you, like the signed surgical consent means like 30% of these people were able to sign their consent, the rest were. And I think this kind of frames the population we are putting this in. These are very elderly, very geriatric. Almost all of them, their past medical history had like all the acronyms. Most of them have oxygen on. It's like you just see these people come through the door, the X-ray, just a quick look at on the bed, like that bone is just not going to be great. So in my mind, these are like ASA 4.5s, anecdotally in my own bias, but this is what our preliminary demographics was. And just breakdown of the fractures. In general, most of them were kind of periprosthetic, interprosthetics, kind of like mid shaft, distal femur, depending on where their implants were. You all can see the breakdown, but most of them were distal femur and interprosthetics. So kind of an assortment of different fractures that we were using this for, which I think kind of shows the multitude and diversity of what you can use it for. But a lot of it was around other hardware because it's just areas that's hard to get fixation with normal implants. And then just a little bit more of the construct, just so you can see like a lot of this was normal. Our screw density was kind of what you would expect out of someone who's like done a trauma fellowship. Most of these were like a distal femur locking plate with we call it a retrograde photodynamic bone device. So essentially, like we were shooting it through one of the condyles of the femur, going up to the proximal femur. And then a handful of these were with a proximal femur locking plate. So most of these were kind of your distal femur geriatric periprosthetics in a nutshell. So just some of our clinical data. Most of them, almost two-thirds, were weight variance tolerated right away, depending on the construct we used. A lot of the ones who were not typically had like ipsilateral injuries, and that's why they were not. Or maybe I think one or two of them, it was like really early on. We were like, ooh, a little nervous about it. But then, I mean, anecdotally, I mean, Halvorson can talk to this, I can talk to this. If like these geriatric patients come in, like we're doing constructs so these people can walk. And I think the IlluminOss kind of helps that for sure. Um, of the people that weren't walking right away after about 8.5 weeks, they were. Interesting thing that especially in the distal femur kind of dual implant data nowadays, there's some of the stuff we've also published on other constructs of like how much increased assistive devices are these patients using at like the end of our treatment observation. So for what we saw was about half, which just in my observation, like we also published the dual plate stuff, and that was actually like almost 60%. So it's similar, but maybe even a little lower. Um, Blood loss, 250 cc's, so almost a unit of blood for everyone, which I think is pretty standard. We weren't able to like totally find significance with that, but again, I think it's because we have a small cohort, and I think anecdotally, both Halvorson and I would say this balloon goes in very percutaneously. Like that is the not where the blood loss comes from. It comes from like the lateral plate or the nail or something. So. Um, Again, you can see that most of these people got a unit of blood post-op. And then just clinically, like I think one of the things we had a question of, because we were seeing, like even when I was a resident with Dr. Halvorson, it's like you were seeing these people heal, and it was really cool. So like to quantify it, we actually, took a modified Rust score of these femurs and just looked at these people in their follow-up. And you can see by their final follow-up, a Rust score of 10.7 essentially said they were going on to union. Like almost essentially every one of them was going on to union. So it was pretty cool to actually see that in data. So just to kind of show what we were doing, we'll kind of get into some of the cases. A lot of it is what the data is kind of like the cases we kind of do, mostly distal femur, interprosthetic, periprosthetic. And then I think Halvorson's got some of the more wacky and wild stuff that we all love to do. But there's a lot of applications for it. Like I'm early in my career and you can find really useful ways to use it. So I'll start. This is one of mine. Typical, 97-year-old ground level fall female. You can see the soft tissue window. It's not ideal. It is closed, but you can see it's an intra-articular distal femur in really, really bad bone. Again, you can see her past medical history has a bunch of acronyms, which just turns you to know that her bone is not going to be good. But at home, before all this, she ambulates with a walker, is relatively independent. So these are the people that nowadays, this is where all the energy of a lot of our femur research goes into. Like, how can you get these people walking right away with a construct that won't fail? So kind of a snapshots of just your CT, like it's an intra-articular femur. So you've got some work to do. And you'll see this is kind of like a little bit more of a complex distal femur, but in general, we reduce the distal block, put some screws in, and then I think what I'll highlight in the methods is the first thing you do before you introduce your balloon, which you can see coming in from the medial condyle, is you got to get your length alignment rotation. And that's what you see with the lateral plate. Essentially, we have that pinned distally and proximally to kind of hold that. And then while that's held, holding a reduction, you start introducing your balloon. But yeah, so these little tungsten helical spirals, so you can see it, it's deflated. And essentially from there, you can see we start inflating it, and then eventually we put our screws and stuff like this. Don't mind this. This is actually a spike. This is not golf club deformity. Trust me on this. You can see it on these subsequent x-rays. So, this is like a pretty, she had a bad intra-articular block, but once that was secured and you kind of hold it with the plate, essentially it's just a sawbones. And this person was weight bearing installer right away. And she came back to clinic actually a couple weeks ago and she was walking on it with her walker. She's almost, I'm not going to say she's back to her baseline, but at this point, she was only like 6 weeks out and she's walking on it, feeling pretty good. So this was kind of like a repeating story that I saw as a resident, as a fellow, and now as practicing attending. So it's pretty cool to see how stable these people feel on these things. So in general, like the general sequence of this is you make the bone a sawbone, so you reduce it, hold it with typically with a plate or something else, put in your IlluminOss, inflate it, and then you essentially just drill and fill from there. So in general, you can see here's another example. The femur is reduced, length line rotation is established. Most of these are metaphyseal fractures. So as long as that's set, it's not an anatomic reduction, it's length line rotation. And then you can do your balloon. There's multiple ways to introduce it. This is the curved awl that comes in most of the sets. The other way is you can just use like a threaded guide pin like you would use for a nail. And then they have like a cannulated drill bit to get access to the canal. But in essence, eventually there's a ball tip guide wire and then a sheath. And then eventually you introduce your balloon of varying size and length, diameter, and then sequentially blow it up. So I'll let Halvorson take over from here.
Yeah. So I've done about I don't know, I think around 100 or so patients and 125 sort of balloons. Some of those have been metastatic. A lot of those, though, have been traumatic. This is sort of just a flight of ideas, and unfortunately, this is kind of what goes on in my head. So I apologize that you're going to get a glimpse of what's up here. But I found a lot of this is just rapid fire kind of cases, getting thought discussion and sort of getting people kind of used to thinking about this in different scenarios, different patients, different idea, different kind of fracture patterns, locations, kind of a thing. And so again, we're just going to kind of rapid fire go through some of these. Paraprosthetics is kind of the still my workhorse, where I think about this and sort of where I do it. I've done it in the tibia. I've done it, like I said, for kind of geriatric acetabulum for total hip. Done it in upper extremity humerus and sort of pathologic acetabulum and certainly pelvic ring kind of injuries as well. But paraprosthetics, interprosthetics are still kind of my workhorse. So this was one that I sort of started to realize I could sort of push the envelope a little bit with sort of how much bone I have around total knee replacements and distal femur fractures and sort of paraprosthetic. So this was an 83-year-old who was from a fall. And if you really look at sort of the 3D recon, there's not a lot of bone there. And so looking at this a little more, this may have been one that possibly could have been better served with the distal femur replacement, or at least that consideration or thought process would be ready for that. I was not really ready for that. And so when I got to the operating room, you sort of looked at it, and I had a bugger of a time to sort of disimpact and disengage that anterior phalange of the knee replacement from that distal femur. And so when I was able to do that with a freer, right, obviously there was nothing behind there. Right. So this was kind of that oh crap moment of I don't have a lot of bone. What am I going to do to support this? And so I ended up slapping on this lateral plate and actually sticking a locking screw behind the anterior phalange. That was the only way I could sort of keep this thing in the sort of sagittal plane aligned. but I still had that bone void, right? And so again, thinking of this as both a construct stabilizer, but also a bone augment, able to get an IlluminOss device. So just like Dr. Andring was sort of talking about, this is that curved awl, getting a really low start point on that medial side, grabbing as much bone as I possibly can. You can see there on the right-hand side, the actual introducer sheath that is there. After we sort of reamed, you sort of put that in, you slide this balloon in. So all of this on that medial side is done through an incision about a centimeter long, right? So really minimal blood loss, very quick, very easy to insert, very easy to do. And this is that balloon that is sort of then inflating over time. And you can see it get bigger and bigger, and lo and behold, you can actually see it come out of the bone, right? So there literally is no bone along that medial column. And this is the lateral, and you can see again that that balloon is sort of supporting that anterior phalange along that medial column, right? So I've essentially reconstituted that medial column of the femur, the medial side, with the IlluminOss. And now, like Dr. Andring said, keep it simple, right? Keep it simple, stupid, right? I had length, rotation, and alignment. I put my IlluminOss in, I have my support, now it's fill and drill. And so there you go, right? Putting the sort of the screws into the IlluminOss, right? And kind of creating that married construct, that sort of triangle of medial column, lateral column, and then across the joint surface there as well. I was a little bit scared on this one. And so again, I added what we kind of termed a twisty plate, which is kind of extra fixation along that medial side. I didn't Given the bone loss, given the comminution there, I didn't really trust just the IlluminOss alone. I got a little scared. So again, added sort of medial fixation there. Don't judge me on my twist. This is not my best twist plate, but lo and behold, it sort of worked. Came back at 10 weeks, walking on it, no pain, healed, and really no issues or problems to things. So again, once you sort of start doing this, right, you have your arthroplasty partners, and they say, well, Halvorson is kind of pushing this. I don't really want to do a distal femur on this lady because she has the CAD and the CKD and the DM and CHF and all the acronyms that Dr. Andring was talking about within our papers. So can you fix this, right? And first glance, you kind of look at this, I get scared. My phalange is inside my femur, right? I don't have a lot of distal bone stock there. Fracture patterns look like they are below the level of that kind of anterior phalange on the AP. And so again, do I have enough bone stock there, right? And you can kind of see this in the operating room. And again, that fracture going extremely low, at least for me anyway, getting a little bit nervous about how much bone I actually have there for screws. But again, kind of follow your principles, right? Keep it simple, stupid. I got a plate on here. I can get my length, rotation, and alignment. Like Dr. Andring said, we often will kind of use that collinear clamp just to help stabilize things and keep things in line with that lateral plate, right? And just like that last case, that IlluminOss kind of goes up the medial side through a percutaneous incision, right? And again, it sort of comes out that bone, right? So there is no bone along that medial column, right? It's great to put it there, at least in my mind. I used to, when I first started, I had that lateral incision. I'd put it through kind of on the lateral side just so I didn't have to make an extra incision. But again, thinking biomechanically, you're right, your femur wants to tip into varus with every step. It spends its whole life going into varus. If you can keep that buttress along that medial column, right, it'll help prevent that varus deformity that we all often see with distal femur fractures when they go on to non-union or malunion, right? So again, restoring that medial column here with that IlluminOss. And then again, at this point, it's just fill and drill, right? And again, because of that blowout, because of that problem along the medial side, added a little extra fixation there, but all of those screws distally in bone, but also within IlluminOss, not relying on that osteoporotic bone, not relying on sort of bone void, but actual fixation there. There's the AP and the lateral. And so again, another one here. Can you fix this? Same kind of a concept, right? Femur inside, sort of touching almost that base plate on that femur. When you're going to pull this out, there's not going to be a lot of bone there, right? So how are you going to deal with that? Is that a distal femur replacement? Do you fix it and just kind of hope it's going to be screws are just going to kind of be in air, right?
Real quick, there was a question which was about the first case, but probably also about this one, like why not a DFR? Curious your answer, Halvorson, and I can give mine if you want.
Yeah, I think I think you certainly could do a DFR. I don't think there's potentially anything wrong with that. I think our data is now showing, and we got some other data coming out on sort of the dual implant fixation and a lot of the trend with dual implants and especially dual plates and now twist plate and things like that. We can really push the limit and get these patients sort of fixed, get them united, number one. with very low complication rate, very low infection rate, very low malunion rate, very low non-union rate, with probably less expense, and they're still immediately weight bearing. And so again, I don't want to say it's a simpler surgery, but it certainly potentially has lower complication rate and has a very similar outcome to this. And I think there's some decent data now to show too that if you can fix it, you probably have at least a equivalent, if not a little bit lower complication rate than doing a DFR. So for me, if I think, I'm like I said, pushing the envelope a little more because I've been super happy, knock on wood so far. I'm sure tomorrow in my clinic, someone will show up and it'll be a disaster and I'll have to recant the words I'm saying right now. But thus far, with fixation and including the IlluminOss and sort of dual implant, I'm able to kind of stretch that limit, still get these patients up, still get them walking, and they still heal. I don't know, Dr. Andring, if you have differing opinions.
No, I agree. So like I actually do DFRs to Halvorson's chagrin probably. But like I do them for like really, really, really bad ones, but I also trained with people like Halvorson and then my fellowship, like I fixed things that I was like, no way this is gonna be fixed. But I think with the current constructs and technology we have, you can get enough fixation in these and these people heal, they walk on them right away. Like it's pretty impressive. And then the DFR versus ORF thing is going to be debated probably forever. That's a really hot area of discussion right now. But I think in general, like the clinical scores are better with ORIF of some sort. And I don't know, there is some every time I've done a DFR, putting all that metal in there, my blood pressure goes up with just the infection risk. So I mean, those are my biases. You get a separate bias from a recon guy, but I mean, I do both and I would prefer fixing it if I can. So,
Yeah, that's great. So again, similar concept, keep it simple, right? I put this one in here just because it's a little bit different. It's the same idea. Again, lateral plate, length, rotation, alignment. Got my IlluminOss in there, but didn't love sort of that translation over there. Again, it's sort of flexible enough, right? That if you sort of add that medial plate, sort of one of the benefits we found of sort of that dual plate fixation is you can kind of squeeze that bone together, help your reduction. But with the IlluminOss in there, I still have that fixation, right? So in osteoporotic bone and bad bone, if I did this, I would be relying on that osteoporotic bone to hold that reduction once that collinear clamp comes off. Now I don't have to worry about that, right? Now I have fixation within the IlluminOss. And sort of lo and behold, once the clamp comes off, everything sort of stays put, everything stays aligned. And again, they come back at 3 months walking, no pain, no problem. Interestingly enough, the one screw in the medial side that was not in the IlluminOss is starting to back out, right? So that's actually a common theme that I've seen as well, in that screws that are in the IlluminOss, even in the 90-plus-year-old population, extreme ghost bone, osteoporotic bone, that hardware sometimes starts to fail, but the screws that are actually in the IlluminOss don't fail. So this is the one we did again, and probably to Dr. Andring's point, and much to my chagrin, this one may have been a DFR. But again, she was elderly, demented, had lots of medical problems. My joints colleagues weren't super excited about putting a DFR in her for infection risk and complications. But you can see the same kind of issues, right? The femur kind of inside the femur, right? The anterior phalange in the distal femur. When you pull that out, you're going to have no anterior bone there whatsoever. How are you planning to fix that? How are you planning to support that, right? Just with screws, fixation alone, bone grafting, cement, I don't know. So you get to the operating, and there's the CT scan kind of confirming what just not a lot of bone there. I don't know, Dr. Andring, you fixed this? You
plenty
did.
of bone, plenty of bone.
Bone, I agree. So that's what I said too.
Yeah, I mean, like I actually was talking with one of our residents the other day about this. Like they're like, "Oh, when do you do DFR? When do you fix?" I mean, I'd be curious what you think. I think generally people who are like a lot of these who are very low demand, you can fix them. Like I think they generally do better with fixing, who have like very little bone. Whereas the higher demand people, maybe those are the ones like higher demand and it's just totally dusted and there's a few osteocytes on the total knee. Like maybe those are the ones that you do a DFR in. But again, like I have no, that's just what I
Yeah,
think.
for me, if I see loosening on the X-ray, and that's really it, right?
Yeah.
Uh, I see a coronal sagittal split, right? I know that fracture line goes out, right? I see my lateral. and sort of medial femoral condyle dissociated from the total knee, or the total knee is off within the AP or the lateral, and I
Mhm.
sort of sense that it's loose just on an X-ray, then that's probably a DFR, right? But
Yeah.
again, I've started sort of really pushing that limit of, like you said, there's plenty of bone here that I can sort of grab, and with technology and certainly IlluminOss too, then to try to grab even more and sort of use the IlluminOss for that augmentative sort of fixation, not only stability, to sort of get things. So length, rotation, alignment, I got it locked in. I've got my balloon going up and my reamer, Seldinger technique. It's beautiful. I blow the thing up, right? And it sort of just starts to blow out, right? To Dr. Andring's point, you really got to watch the balloon sometimes as it's blowing up, that you start getting a malreduction, or you start sort of creating comminution, right? So it almost looks like my medial side is sort of escaping at this point, right? So this is again kind of one of those great what do I do moments, DFRs. So I have to call my, partner and say I totally screwed up on this one, which I'm not going to do. So, but again, similar to that last one, right? Can I use that IlluminOss as just sort of my buttress, right? I've restored bone, right? I've restored augmentative bone with the IlluminOss along that medial column. Put that medial plate on there. Use the plate to kind of reduce things. But again, I've got the IlluminOss there instead of just bone, right? So have that IlluminOss inflated, and again get a bunch of fixation sort of within that. She was supposed to come see me. Unfortunately, with all the snowstorms and stuff like that, she didn't make it. So I was hoping to have sort of a follow up for you on this one, but not yet. She's coming actually on Thursday now. So next time. Next slide. So what about interprosthetics, right? So interprosthetics are still a big problem for trauma surgeons, right? And this is still just like periprosthetics, kind of one of my workhorses for the IlluminOss in general. And this is where I get a lot of stability from, right? So if you kind of look at these, this is a problem, right? And I know Dr. Andering did a lot of fun stuff that I've taken away from some of his mentors and things within fellowship as well. But obviously, distal femur, again, it goes pretty low, right? It's going into that knee joint. And again, you have a really big total hip up top. So, Dr. Andrew, any thoughts on this one? How to fix IlluminOss or not?
The inner prosthetics is like, I think this is where literally like the first case I did with you was, and I think this is probably one of the best reasons because you have this huge stress riser below a total hip stem or an intramedullary, like a hip nail or something like that. And then you've got poor bone stock distally with a total knee. So to me, that like it's funny when we sit in conference with the residents now, like if I see this and then they're geriatric, low demand or something like that, like they're getting a balloon and a long periprosthetic plate. Like there's no ifs, ands, or buts about it. Like it's just that's the only way that I feel comfortable getting these people up walking and confident that they're going to heal it and I'm actually going to see them and follow up.
Yeah. And that's a great point, right? So the goal with all this dual implant sort of talk, right? Number one, we want things to heal. Number two, we want function. We want them to weight bear. We want them to get up and walk right away. And I'm just not comfortable. I know there's some data out there to show a lateral plate alone is enough to get these people up and walking. I'm still scared with that, right? Again, the femur wants to spend its whole life going into varus, a lateral plate alone on sort of the tension side of a bone with comminution on the compression side. It's going to want to tip into varus. It's going to want to fail. So again, that's kind of where I started with this as well, is trying to get these people up and walking and moving and having sort of a solution for the interprosthetic. And so again, not surprising for this one, length, rotation, and alignment. Get a nice long lateral plate on there, get that collinear on there to sort of reduce things. And then again, up that medial column, right? And a very similar to what we have seen previously. If you kind of look right there at that medial side, there's not a whole lot of bone. Lo and behold, you blow it up and it comes out of the bone there. So again, really supporting that medial side, really restoring that medial column to that femur, adding that support to that lateral distal femur plate that you sort of put on there. And again, sort of get this sort of end construct here. And this was one of those earlier ones where I get a little bit scared and sort of add that sort of medial support there too, just because of that lateral wall blowout. But so adding that plate in addition to the augmentative IlluminOss within that medial column. You can pass the balloon over the implant, which is sort of nice. And so did that, not thinking that maybe I would need a medial plate, but kind of reducing that stress riser there as well, which is cool. And again, at 6 months up, walking, no pain. no issues. Same kind of a concept here. We'll go a little bit quickly so that we can make sure that we get questions. But again, low fracture. These get even harder, right? Because some of these are sort of distal third femur fractures and interprosthetic and sort of low, right? So you don't have a lot of bone within and in between, sort of that fracture and working length between that fracture and sort of the distal tip of the hip stem. And so again, like Dr. Andring said, for me, this is 100% an IlluminOss that sort of gets me that fixation that I sort of need in between those two sort of prosthetics, and also gives me something to sort of bite into for that osteoporosis. So length, rotation, alignment, again, next throw in the balloon, blow it up, and you start getting sort of then that fixation. Along that medial column, you can sort of see it going up and then sort of just blowing up and really restoring that whole sort of segment within that sort of medial column and sort of that extension into that metadiaphyseal region. So again, even though on this one I did not put sort of that medial plate, right? I let them immediately weight bear, thinking that this was, again, a similar construct to a plate nail construct. So immediate weight bearing, get them up, get them moving, and lo and behold, they come back at 3 months, ambulating, no pain, and you can see that bony healing callus sort of forming at that time.
I would say the other thing to add that I don't think we've highlighted enough is like these, like especially these distal femur locking plates, we are filling most of those locking screws distally like after the balloon's blown up. So we try to target as many as possible into that balloon. And you know, when you drill through it, you know it's in the balloon. So just that's a real key to these.
You go back a couple slides. So that's a good point, and that's actually a great point. So within the technique, I will, number one, tell the residents that it's going to feel unicortical when you are drilling this, because it does feel unicortical. It feels like cortical bone, right? So when you're in the shaft and you're sort of drilling that cortical screw, you won't feel a bicortical sort of sensation whatsoever, right? And so the first time the residents typically do it, they will plunge all the way through because they feel as though they are unicortical, right? So telling them that it will feel unicortical, I guarantee it's bicortical, just be very careful. And then secondly, sort of on the insertion, like Dr. Andring said, I will take at least a couple shots to ensure that my awl and my starting awl is sort of dead center on my plate, right? To sort of concentrate the IlluminOss balloon wherever I'm going to blow it up into the distal cluster of screws, right? So that I get enough fixation in the IlluminOss. So that's a great point too, in trying to sort of capture as much IlluminOss, sort of as much stability as you possibly can. All right. So what about native femurs? What about distal femurs? What about just the kind of elderly osteoporotic or the Vancouver C, right? Kind of just below the total hip. So again, just like this has sort of helped me push the envelope as far as paraprosthetics, interprosthetics, bone quality, distal femur, I am not a nailer. I'm a self-professed not a nailer. I'm a plater, right? But plates have their problems, right? And so osteoporosis, you're relying on screws, you're relying on the metal, you're relying on the bone, right? And if you don't have a good host, whether that be end-stage renal osteoporosis, et cetera, you don't have a lot of great options of things. So this again is a 91-year-old distal femur. I will tell you that CT scan showed that it was extra articular, right? But again, one of those at like kind of 5:30 a.m. on a trauma conference, you're like, yeah, just post it. We'll fix it. It's not going to get a total knee replacement. It's not going to get a distal femur, but get it to the operating room and get this. And you're like, oh, there ain't much lateral bone there whatsoever, right? And as I pulled it out, you can kind of see the missing anterior cortex there, just right above kind of where that articular surface is. So got the nail in, didn't love kind of where my distal segment was sort of sitting, right? Got a lot of valgus there, got my interlock screw in there. I'm trying to sort of fix it, don't love it. So pull that interlock out and then sort of redo and sort of get less valgus in there, induce a little bit of varus, get the interlock from the other side and kind of peg that lateral distal femur there. But then think about, can I augment this, right? Didn't plan on it, right? But again, once you kind of think about ideas about where this can be used, kind of the sky's the limit, right? So can I nail within a nail? And can I augment that nail fixation? Can I augment the bone even with that nail? Get the benefit of a nail with the osteoporotic bone, the weight bearing, all that stuff that I want in that 91-year-old. So got that kind of, again, nail in reduction, just like a plate, right? Keep it simple. Got my length, rotation, alignment, and then got my IlluminOss in there. And you can see the balloon kind of going in and then the balloon sort of blowing up, right? And so I've got that lateral fixation there, that lateral column, and that anterior sort of support. Like we just talked about, if I'm careful, go back one slide, sorry. if I'm careful and I can kind of put that where I want it to be, I can center that, right? So really the only screw that is not in the IlluminOss at this point is that initial interlock screw, right? And again, I've still got lateral wall blowout, right? I've still got all sorts of stuff, but I got my length, rotation, and alignment. And she literally comes back to clinic at, no joke, last week, 8 weeks. She walked in the clinic, she got her x-ray, and then she just walked out. She actually wasn't even seen. I guess she didn't think that she needed to be seen by a physician, but this was her x-ray. All right. She's been walking on it. I saw her in the hallway walking. And you can see again, the only screw that is sort of backing out is the one not in the IlluminOss, that initial sort of interlock that was in that lateral column. So again, a nail within a nail kind of concept. Same kind of idea here, 85-year-old dementia. I know they're going to walk on it. This is ghost bone. This is shell bone, right? So plates and screws, I know possible, right? Dual implant. I can twist plate this. I can lateral plate it. But I know the bone quality is going to be extremely poor. So can I augment, right? Can I get a weight-bearing device, right? But actual augmentation with the interlocks, right? Augmentation with the screws. So put the nail in, get my length, rotation, and alignment, and then sort of add that IlluminOss device to things. No different than sort of a plate and IlluminOss, just now a nail and an IlluminOss. You can see it blowing up there. Again, the screws lateral to medial in the IlluminOss device. And she comes back at 8 weeks and is walking, no pain and no problems whatsoever. Next one, same kind of a concept, and we'll kind of get going here. 92-year-old. Again, when you pull this out, just like anything, you're going to have a big void there anteriorly. CT scan shows it's extra-articular, right? So again, could you do a distal femur? Sure. She's 92, poor bone quality, demented, all the medical things. Can I fix it? Can I get her up? Can I get her walking? Plate and screw construct probably would work, right? But again, worried about bone quality, worried about bone stock there in that 92-year-old. And so again, nail it. And then in this case, because both sides were sort of comminuted, did kind of a double balloon, both lateral and medial, and sort of inflated both then at the same time. Got sort of a triple fixation then within that distal femur and got good stability there with screws sort of through things. 91-year-old dementia, again, sort of an intra-articular B-type, medial B-type kind of fracture to things, but a total hip above, right? So how do I protect this, right? I certainly can't nail it necessarily, not a great fracture to nail. I could do plates and screws, right? But I'm still going to have to sort of bypass or think about that sort of interface between that total hip stem and my plate. So is there something else I can sort of do, right? I don't need to go that long on my plate. And so I can use that IlluminOss device to sort of bypass things. So you can see that guide pin sort of going above the hip stem proximally there in preparation for getting that IlluminOss bypassed across that stress riser. Fix the distal part of there, got one sort of single screw across there along with that collinear clamp, and then sort of insert my IlluminOss device kind of up and through there, blowing it up, bypassing that stem. So I've sort of negated any stress riser there in this 91-year-old demented person that I do not want to fix an intraprosthetic at all, and then sort of fix things like I normally would in a simple kind of anti-glide fashion distally there. And they can come back at 8 weeks. They're ambulating, they have no pain, they are getting up and they are moving. So I can't help but the curious. I am sure that there are going to be, within this series, there are some great people that will talk to you all on kind of how they're using this device and what they're doing. Geriatric acetabulums. I know Dr. Andering has done a couple of those with IlluminOss sort of fixation with total hip replacement, and having that total hip replacement both for revision as well as for acute acetabulum, having that device there that you can screw into, you can ream into, you can have a backdrop into, tibia, tibial nails and sort of nail the tibia, humerus, pathologic pelvis, all sorts of fun things. So one kind of thing on the horizon there, just to kind of wet the whistles of everybody, are sort of pertropes, right? And how we can sort of do this. This was interesting. This was a dual implant carbon fiber fixation that was done in Tennessee, and then ended up in our clinic after having an MVC and a pertroke. He had end-stage renal disease, all sorts of things, walker at all times. Huge surgery, obviously, to take out 2 carbon fiber implants. We don't even have that at our institution. I couldn't even find the rep to even bring the stuff in. So I'm sort of left with these implants and how to fix things. And so again, can I use that IlluminOss to sort of augment the bone, proximally bypass things, give me a stable construct there? So just like a nail, and I know Dr. Andring has sort of some experience with this in fellowship, kind of using this as a pertroke calcar replacing sort of support. So again, right along that medial calcar, you can see that nail kind of go in, and then sort of using a proximal in this case, a distal femur plate as a proximal femur plate, to sort of go into that device and sort of use that as a perch rib. They come back actually at 8 months, sorry, at 8 weeks. You can see that they're actually tipping into a little bit of varus, if I'm going to be honest. But all of those screws are still in the IlluminOss, and they are up and they are walking, and they actually don't have any problem. And they are set to come back and see me in a couple of weeks. So again, I will put this on the next slide and sort of show you. This is another one, 84-year-old ground level fall. Obviously a previous sort of implant. Again, just sort of goes to show you you can't protect the whole bone. That's a misnomer. There's no way to do so. Periprosthetic long nail, right, protecting the whole bone, but a periprosthetic kind of fracture distally there. I would
Nice
love,
wedge effect of that nail too.
yep, exactly. I would love to retrograde nail this, right? But big hole up top there, sort of within that femoral neck junction on things. So how am I going to protect that? And an 84-year-old certainly don't want to do a retrograde nail and then come back and do some kind of a hemiarthroplasty when they, fall and break their femoral neck after my retrograde nail. So decide to take things out, do the retrograde nail, but then sort of fill that void up top there with those cephalomedullary screws and that cephalomedullary device with an IlluminOss and kind of create a cephalomedullary nail married between the retrograde nail and the IlluminOss. They came back at 3 months, up, walking, moving, no issues and problems, and sort of had healing distal and had no problems up top. So anecdotally, I've certainly had 2 to 3 conversions to mega prosthetics in sort of the distal femur. A couple of people had a malunion and a couple of people had a non-union, in those kind of things. But again, argue that 2 to 3 in this patient population is probably equivalent to almost any other form of fixation that you would have. No infections related to the device. And like I said, in addition, kind of 2 or 3 malunions, mostly in end-stage renal disease and extremely sort of osteoporotic folks. But they don't require revision. They are up, they're walking, and they're moving. So it works. It's a great sort of tool to have within your armamentarium for this patient population. So in summary, again, it's easy to insert, and the soft tissues are really not an issue with minimal complication risk. It's a bone augment, right? You don't really rely on the patient's bone quality, and you really just make up for missing bone. And it is also an intramedullary implant. It's a dual implant and provides that inherent stability for these patients. And so, again, like Dr. Andring said, for those inner prosthetics, for those really low periprosthetics, for those osteoporotics, that you just don't know what to do with because your screws and things are not going to have any purchase. This is a wonderful thing to kind of have just at the ready, just kind of throw in to kind of help that function, to get them up, to get them walking. And like I said, it works. I don't know, Dr. Andrew, any kind of other comments or results or any anecdotes, especially from your fellowship? I know, like I said, Dr. Lee is sort of pushing the envelope a lot with this as well.
Yeah, he's doing some things. I mean, I can't comment on those because he's keeping those close to the heart, and publishing probably at some point. I think the keys are like who you putting it in, right? Like I feel like the people that we're putting these in, and like Halvorson and I have said, like we see their X-ray at morning triage, and we automatically are like, oh, they're getting a Luminos, right? It's the same patient every time. They're very old, they're very sick, and they've got this highly comminuted femur fracture that just needs extra support, more augmentation. So I think those are the people, like I think the younger people that break their femurs, like they don't break this way, right? They don't need all this extra support. And those are the people that, a lot of them you can get away with just a lateral lock plating. You can keep them non-weight bearing for an amount of time, but like a lot of these patients you can't. I think the only things I would say like, that are options. So a lot of times I think even for myself still, like most time the balloon is going through like the medial or lateral condyle, but another way you can do it is you can do it just straight up the pipe. It's kind of like just like a retrograde femur nail. And like we did a lot more of that in fellowship, and the idea is it's more on axis. I don't know if you get as much of, those your lateral plate, get your screws all the way to the medial column. Biomechanically makes a little more sense to me, but it's just another option for you. But I think like a lot of cases you showed, it's just kind of being curious and finding new ways to use it, have really helped. Like for me, like early in practice, like I've found some pretty creative ways to use it that have given me a lot more confidence in letting people walk on it.